Welcome to AETCM, the emergency medicine channel. A 21-year-old female was brought to our ER with alleged history of deliberate self-harm by consumption of approximately 15 tablets of tablet etizolam 0.5 mg, tablet Nexito LS, which the content of which was tablet escitalopram 10 mg and tablet clonazepam 0.25 mg. So 15 tablets into each, total cumulative dose of around tablet etizolam of 7.5 mg, escitalopram of 10 mg and clonazepam of 3.75 mg.
So what all are they?
Escitalopram is a selective serotonin reuptake inhibitor, whereas clonazepam and etizolam are benzodiazepines. So she was brought into our ER within 1 hour of consumption of the tablets. So on initial 10-second assessment, airway was patent, there was no secretion. Breathing wise, there was air entry bilaterally, which was equal, with a respiratory rate of 18 per minute and saturation of 100%. Circulation wise, her BP was 90-60 with a pulse rate of 88 per minute, with all pulses equally filled. Disability wise, GCS was full, E4, V5, M6. Patient was a bit drowsy but arousable, giving history. Pupils were 2.5 mm, equally reactive. Exposure wise, temperature of 97.9 degree Fahrenheit and a GRBS of 86 milligram per deciliter.
Okay, so specifically to SSRI toxicity and benzodiazepine toxicity, what all things will you check in ABCD?
ABCD, mostly the patient will be drowsy.
Because of benzodiazepine.
Okay. So patient will be drowsy, and in case of serotonin,
always patient won't be drowsy. Sometimes patient will be very agitated. Sometimes seizures. This thing can be there. Okay.
So patient can be drowsy. Patient can be agitated also. Then, if patient is agitated, if serotonin intake is on the higher level, the patient might have hypertension, tachycardia will be there. Patient will have temperature, hyperthermia can be there, muscle rigidity, all that can be there. Sweating will be there.
So, and benzodiazepine overdose can go into
depression. So, bradypnea will be there.
Bradypnea, desaturation might be there.
Since patient was brought to our ER within one hour of ingestion, we went ahead with gastric lavage followed by gastric decontamination with 50 grams of activated charcoal. Following which, we took the adjuvants to primary survey. We had inserted the rice tube and we proceeded with the gastric lavage and activated
sampling
charcoal.
Was taken.
And sample was taken for toxicology screening. Then we went ahead with the adjuncts to primary survey. We took an ECG. ECG was normal sinus rhythm with a heart rate of 62 with the QTC of 446. And VBG.
So we are mainly taking ECG to look for any QTC prolongation because of SSRI.
Then VBG we took. VBG, there was no electrolyte imbalance. There was no acidosis, no acid base abnormality.
Yeah. So what is the main purpose of taking an blood gas?
If sensorium is low, we have to rule out other causes of low sensorium. Even though we know it is a poisoning, we have to rule out any hypoglycemia, any hyponatremia, any electrolyte imbalance. Also, metabolic acidosis can be there in case of if co-ingestions are there. If patient has to take other antidepressants, any tricyclic antidepressants to the other co-ingestions. So.
So, if there is any, otherwise, if the patient has taken some propylene glycol,
that
diluents are there, then the patient might have, because of that, because of the diluent effect, patient might have lactic acidosis, metabolic acidosis, hyperosmolarity and all. So, that should be checked. Okay, so mainly when a patient comes with an SSRI overdose, our main target is to check the QTC for any QTC prolongation, whereas in benzodiazepine overdose, we need to look for any respiratory depression features. So, we have to look for a PCO2 retention.
Okay. Coming to sample history, 21-year-old female with no known comorbidities consumed the following tablets at around 7:30 am in the hostel. Which her roommates witnessed, and as soon as they saw that, they took her to the warden, and followed by that, they brought her to our ER. She was recently started on these medications 5 days back by her psychiatrist because of some ongoing problems within her personal relationships, and because of a fight which happened with her boyfriend, she took these medications in the morning. She's not allergic to any known medications.
So recently only these medicines were introduced.
Just 5 days back.
So is there anything, so suppose this patient is not is coming to you with altered sensorium, but there is no history of overdose. So what will you suspect? Like suppose a patient was taking some SSRIs, there was a recent dose change or any something like that. Without any drug overdose also, we'll have to suspect a serotonin syndrome because of the excessive serotonin. So any drug dose change, we even without the history of overdose can go into serotonin syndrome or NMS.
There is no similar history in the past. He has never attempted any no suicidal thoughts, no similar history in the past. Then coming to examination, all examinations, all systemic examinations was within normal limit. So we went ahead with admission and observation for the patient for at least 24 hours. Repeated ECGs.
So for an SSRI overdose, how much time you need to observe?
SSRI at least 6 hours, but if QTC prolongation is there, 24 hours admission and observation is required.
Okay. So, so what will you do if there is a QTC prolongation?
If QTC prolongation is there, we have to treat the patient with sodium bicarbonate. Also, we have to monitor the ECGs, as this can predispose the patient for any torsades de pointes. So sodium bicarbonate, we will treat the patient with 1 to 2 milliequivalent per kg. That is at 8.4 preparation percentage preparation that we get. Around 50 to 100 milliequivalents we can give, and we can repeat till the QTC comes in normal range.
Okay.
And if patient in case goes into torsades de pointes, then you have to treat with magnesium sulfate, 2 grams.
Okay. What about the other case, benzodiazepines?
Benzodiazepines, usually benzodiazepines, most threatening is respiratory depression. So we have to look for the respiratory rate and
anything which can contribute to the patient's like benzodiazepine. This patient was drowsy but arousable. So any type of patients can the benzodiazepine cause more will have more tendency for respiratory depression.
Patient already having liver cirrhosis, the action of benzodiazepines will be prolonged.
Not prolonged. The oxidation of benzodiazepine will be high. So the active product will be more in the system. Okay.
So they can be at more risk for respiratory depression.
Then external release tablet. Any patient who, as you told, CLD patient, patients with advanced age, patient who is taking some assaults like antifungals like assaults, or a patient who is having excessive exposure to estrogen, or females can have increased oxidation of benzodiazepine, and the active product will be there in the system. So they might have go into more symptoms of benzodiazepine overdose.
So we had sent for the toxicology for this patient. Toxicology screening for gastric lavage as well as blood samples we had sent. It came positive for all the drugs that we had mentioned earlier. Then within 24 hours, patient did not develop any complications. We had given a psychiatric consultation also, following which we could discharge the patient, and she was asked to review with psychiatry. Then coming to benzodiazepine overdose. Usually benzodiazepine overdose is due to effect of benzodiazepine via the GABA A receptors. They will actually increase the affinity of the of the drug to the receptors, causing increased symptoms. They will not alter the action of the drug, just affinity towards the receptor will be increased. So potentiates GABA's inhibitory actions. Other than that, it is mostly metabolized through the liver, hepatic metabolism. A most dangerous complication that can arise is respiratory depression. So we have to look for that, and it is known as the coma which benzodiazepines cause is usually associated with normal vitals. So we usually mention it as coma with normal vitals will be normal, but the sensorium of the patient might be low because patient will be drowsy. Usually most commonly co-ingested with ethanol. So if any patient coming to us, we should always ask regarding any ethanol consumption was there or not, or we can send the toxicology for concentration of alcohol. We can send for diagnosis, we can send urine toxicology for benzodiazepines as well as blood, but thing is that they are only qualitative. So if patient has taken, they can only tell whether patient it's taken or not, but whether that quantity is responsible for the current condition of the patient or not, that we cannot quantify with the toxicology screening. Management wise, we have to ABC, airway breathing circulation will manage like that. If breathing, any hypoxia is there, oxygen to be given. Any ETCO2 monitoring can be done for patients at risk of hypoventilation, PCO2 retention. And also we have to rule out other causes of low sensorium like serum glucose, any hyponatremia, any history of recent trauma to the head, or any other associated symptoms where an imaging of the brain might be needed. All have to be ruled out before considering, before attributing the sensorium to benzodiazepine. We have a antidote for benzodiazepine, that is Flumazenil. Flumazenil.
What is the dose of Flumazenil?
Flumazenil we can give at 0.2 mg, and we can repeat it as 0.3, like in doses of, first dose of 0.2 mg IV, followed by 0.3 mg, 0.5 mg, but maximum of, we can give 3 mg in an hour. We'll give up to 1 mg. Then in case the patient again becomes drowsy, we can repeat the doses, maximum of 3 mg in 1 hour. Since it is a competitive antagonist, even after since and half-life of Flumazenil is 1 hour, so even after we give Flumazenil, patient might again become drowsy if benzodiazepine starts acting again once its half-life is finished. So we'll repeat the doses.
Any contraindications to give?
So Flumazenil can't be given in patients who have previously taken benzodiazepine. Means
who is on
benzodiazepine
routinely.
Patients who are known case of seizure disorder on benzodiazepine cannot be given. Current episode of benzodiazepine toxicity, but with witness seizures in this episode, they can't be given. Also, it should not be used as coma cocktail, which was earlier used. And then patients' history of and also with patients who are taking any other pro-convulsant drugs like TCAs, such pro-convulsant drugs, Flumazenil should not be given to such patients.
So main problem with Flumazenil is
withdrawal. It will cause withdrawal and then seizure.
Seizures will happen. So when we have a patient who is already a known case of seizure disorder, we are not supposed to give. Like if the patient is having any co-injections, we are not supposed to give. Okay, or any recent history of head trauma or anything, we are not supposed to give. So suppose we have given Flumazenil and patient develops seizure, what will you give?
We'll have to give benzodiazepines, phenobarbital we can give. Phenobarbital we can give. And then we can give Flumazenil only if it is toxicity, benzodiazepine toxicity occurred iatrogenically while any procedural sedation. We gave for sedation and dose became high, then we can give Flumazenil for that. Or in children where we know that patient has consumed only single injection which is causing severe CNS depression, then we can go ahead with Flumazenil.
So what is the dose in children?
Dose of Flumazenil in children 0.01 mg per kg.
Okay.
0.01 mg per kg. Then coming to serotonin toxicity, the most dreaded complication that we have to look for is serotonin syndrome. Serotonin syndrome, we have a criteria to diagnose serotonin syndrome which is known as the Hunter toxicity criteria. According to this, first is there has to be presence of any serotonergic agent exposure with any of the following criteria. That is, patient has exposure with spontaneous clonus or exposure with inducible clonus with agitation or diaphoresis, or ocular clonus with agitation or diaphoresis, then inducible ocular clonus with hypertonia and temperature more than 30 degrees Celsius, or else exposure with tremor plus hyperreflexia. If we have this criteria, then we can say the patient is having serotonin syndrome. So serotonin syndrome, again, symptoms, it's a triad of cognitive, neuromuscular and autonomic symptoms. So in cognitive, we will have altered level of consciousness, agitation, insomnia, restlessness. In autonomic, there will be hyperthermia, diaphoresis, hypertension, tachycardia, tachypnea can be there. In neuromuscular, most important is patient will have a clonus. Other than that, hyperreflexia will be there, tremors, muscle rigidity, akathisia can be there. Serotonin syndrome.
So serotonin syndrome and NMS will be having mostly the same triad, like altered sensorium, hyperthermia and
the only thing is that here it will be hyperreactivity, hyperreflexia. In NMS it will be bradyreflexia. And
clonus, hyperreflexia, everything will be seen in serotonin syndrome. In other, it will not be seen. Okay.
And NMS will occur usually within 2 to 24 hours of exposure, whereas NMS takes around few days to weeks for developing. Then for treatment of NMS, we'll go ahead.
So any drugs that can precipitate into an serotonin syndrome. So if the patient is on SSRI and if we are giving some drugs, any drugs that can precipitate serotonin syndrome?
Drugs like tramadol, then
Mainly SSRIs will cause, SNRIs will cause,
monoamine oxidase
inhibitors will cause,
tricyclic
antidepressants will cause,
SNRIs will cause. And then other than that, atypical antidepressants can cause. And
then drugs like in ER we might like if the patient is overusing like cocaine and all, that can cause a serotonin syndrome. Or if we are giving some antitussive agents like codeine something like that, that also will cause. Then antibiotics like linezolid will cause. Okay, so if the patient is already on SSRIs, when we are giving these medicines, we should have that precaution. Okay.
Then coming to treatment wise,
in serotonin syndrome,
serotonin syndrome, we can go ahead with benzodiazepines. Basically,
mainly the treatment in serotonin syndrome is supportive management.
Okay. Supportive management, and usually if patient becomes very restless and hyperthermia is there, here the agent of choice for hyperthermia is not acetaminophen, because this is mostly due to agitation of the patient. So we have to first calm down the patient. If needed, we have to intubate and paralyze sedate and paralyze the patient. Then go ahead with benzodiazepines if seizures or too much agitation, sedation is
for required. Hyperthermia, what will you do? Cooling.
We will only do cooling. And we can give cyproheptadine, but it is not that much proven. Dose wise, it is 4 mg tablet which is available. We can give an initial dose of 12 mg followed by 2 mg every doses. It is actually an antihistaminic agent, but it has also 5-HT1 and 5-HT2 blocker actions is there. Other than that,
then chlorpromazine also is there, but that can cause seizure, hypotension and all. So some agents are there for serotonin syndrome. Okay.
Then in case of this other DDs, in case of serotonergic syndromes, for initially we have to go ahead with supportive care. Then if agitation, mostly it is better to go with chemical restraint rather than physical dose. Otherwise, patient will become more agitated. We can go ahead
and
with
hyperthermia.
Benzodiazepines, diazepam, lorazepam, we can give. Then if autonomic instability like severe hypertension, severe tachycardia is there, we can use short-acting beta blockers. We can go ahead with esmolol, nitroprusside or nicardia can be given. Hyperthermia management has to be done. Then other DDs which we can think about if we have a patient suspecting NMS, suspecting serotonin syndrome. Other DDs that we should look for is neuroleptic malignant syndrome, then any cholinergic toxicity or any malignant hyperthermia, or sometimes thyroid storm can also present in the same way. Malignant hyperthermia, there will be usually exposure to any halogenated anesthetic, volatile anesthetic agents, or any non-depolarizing muscle relaxants like succinyl and then complication wise, if
it is malignant hyperthermia, what is the antidote?
We have to give
dandrulan sodium. So mainly if the patient, suppose we have intubated with choline and patient is going to, in the rhythm we are suddenly seeing patient is having tachycardia, high BP, and patient is going into that rigidity and high temperature, first main treatment is to stop whatever we have given, stop that, then only consider giving dandrulan. Okay. So this patient didn't have any features of benzodiazepine overdose or SSRI overdose features. So only supportive treatment was given. We monitored the QTC and also for any carbon dioxide retention and respiratory depression. That was not there, so we have transferred to psychiatry.